just coming back again, I do think that the results that we've seen with ipi/nivo in patients with brain mets are remarkable. So in both the Checkmate study published by Tabi et al. In New England Journal and the ABC study published by Georgina Long in Lancet Oncology, ipi/nivo had intracranial response rates between 45 and 60%. One of the things that and again, to your point, what also was so impressive about it is the fact that in contrast to what we saw with dabrafenib trametinib is that almost all of those responses are lasting at least a year and potentially even longer. One of the things to keep in mind is that those patients who were enrolled in those studies, one, weren't on steroids. And so in the real world where we see patients with cerebral edema and on steroids, we actually don't have data for immunotherapy in those patients. And so in terms of extrapolating the results, there are real world considerations. The ABC trial, again, by Georgina Long, those patients actually were not allowed to have had previous radiation to the brain as well. I do think, again, that ipi/nivo for a patient who meets the criteria we saw in those trials, to me, looks like the standard of care for patients who have brain metastases. But I think we're also learning about how do we handle patients, again, who are on steroids, who need sort of quick control, where actually the disease control rate was much better with dabrafenib trametinib than it was with the immunotherapy regimens.
So where do you see still, Caroline, a role for BRAF and MEK inhibitors in the brain met patient population? So what is a clear signal for you to go with BRAF-MEK first and not the immuno-oncology combo?
I tend to prescribe BRAF-MEK when it's very catastrophic, like when the patient is going to die maybe in the following weeks. Sometimes I'm afraid maybe ipi/nivo doesn't have time to work. So maybe I should change, I don't know.
So in the routine, you're not giving it, let's say, for 3 months, achieving a nice response, which is very quick, and then you switch to some sort of maintenance treatment with immune checkpoint blockade?
No, we don't do it outside of a clinical trial because, I know some colleagues do that, but then I don't think we learn anything, and I think it's for a patient who is responding, you change, and especially in this situation, sometimes it's very, it can be very severe for the patients not to respond. He was responding, you change the therapy, and all of a sudden things go bad and toxicity, and then if you don't at least address a question and bring some response, I would not do that like widely.
So is there experience actually yet with the flip dosing of ipi/nivo in brain mets? Or none yet. So the 511 trial didn't have any patients with brain metastases.
No.
But I know with brain mets in your hospital, you do intrathecal injection of anti-PD-1. Do you have some preliminary data about?
So not for brain metastases, but we have an intrathecal immunotherapy program for patients with leptomeningeal disease, which is sort of the final frontier of metastatic melanoma. So whereas historically, before our current therapies, the median survival of patients with brain metastases was 4 months, for patients with evidence of leptomeningeal disease, it was closer to 4 weeks. So this, again, is one of the places where there is a truly unmet need for more effective therapies. And to be honest, for clinical trials, these patients have been excluded from all the recent trials for patients with brain metastases.
So